planning is nothing but the planning to fail. So planning is very important, because if we fail to manage these cases, the results in the long term is very poor. We have seen already. This is an example. This is a paper of the famous Stephen Barkert and Jody Beer in 2000. They have undergone the arthroscopic Bankert repair in 194 cases, and their observation is that more than 10% failure rate. So when they retrospectively think what is the cause of the failure, they shown that they have not treated the bony lesion separately. So the instability scenario, the soft tissue lesion and bony lesion are separate, and two separate entities should be treated accordingly. And they have the conclusion that the arthroscopic Bankert repair given as equal as result as open Bankert repair, but in patients with significant bone loss, these are not candidate for a Bankert repair, both arthroscopic and open. And in contact athlete without structural bone loss, the arthroscopic Bankert repair may be the treatment of choice. Basically, when a patient with recurrent dislocation of the shoulder come to us, we see him or her clinically, and we always try to see the Bankert lesion in the MRI films, and we going to treat this Bankert lesion. So apart from Bankert lesion, there are various pathologies. This should be dealt in, and in a few slides, in the next slides, we are going to discuss about that. So most of the failure in bony Bankert, and it is 67% of cases, the failure due to the unrecognized bony Bankert lesion. And the same author published in 2007 about the results of modified Latarjet procedure in patients with anterior-inferior instability with significant bone loss. And they found that the open Latarjet procedure for shoulder instability with the inverted pear-shaped glenoid with associated Hill-Sachs lesion having a good success rate with only 4.9% of recurrence rate. So we have to diagnose the bony pathology by clinically and by imaging. Now, this is a problem case. 25 years male patient, he is a kabaddi player, and definitely is a right dominant person. History of dislocation 7 to 8 times before, and the first time dislocation occurs 4 years back, and it was treated in a health center without any general anesthesia. When we received the patient, the apprehension test was positive, and the other test, that is the relocation test, crank test, was also positive. This is his X-ray. The X-ray of the glenohumeral joint, true AP view, shows that there is blurring of the posterolateral aspect of the humeral head, and this signifies there is a significant Hill-Sachs lesion, and we can assume there is some amount of blurring at the inferior aspect of the glenoid. Now we proceed further. First investigation in this patient is to do an MRI. So we have done it, and this MRI scan shows there is a blurring, the same thing, the blurring of the anterior inferior part of the glenoid rim, and there is a big Hill-Sachs lesion. So there is a bony pathology in that case. So if we find a bony pathology in any patient by a X-ray or MRI, CT scan should be done, and it has to be done before planning. The CT scan is done, and this shows there is a significant amount of bone loss in front of the glenoid, anterior inferior part of the glenoid. So what is the plan now? The arthroscopic Bankart, with remplissage to deal with the Hill-Sachs lesion. Open shoulder stabilization is a age old, but still many surgeons are doing it with a good result. Lateral transfer, coracoid transfer is indicated here or not, we will come later on. And ICBG, that is the iliac crest bone grafting. So there is a controversy in open and arthroscopic method. In 2007, in JBJS, there is a paper come out that it shows that there's an increased recurrence rate with the arthroscopic Bankart repair. But it shows that this in 2007 and this is 2021, the track of the this arthroscopic procedure has been increased, the quality has been increased. Previously it was repaired with two anchors, and it is not associated, sometimes it was not associated with other procedures like remplissage or any other soft tissue procedure. So the recurrence rate was very high at that time. But now subsequently we can see that this time the arthroscopic procedure give as equivalent as result as the open procedure. Now, what is the risk factor for recurrence of the shoulder instability treated with the arthroscopic Bankart repair? These are the bony defect. The number one is bony defect, number two is bony defect, number three is bony defect. Is a cause of the failure of any arthroscopic stabilization surgery. So bony defect has to be diagnosed prior any treatment. Number two is shoulder hyperlaxity. So clinical examination of the patient is very important. We have to see each and every corner of the patient. We have to see whether the patient having hyperlaxity or not. We have to examine the elbow. We have to examine the knee, examine the spine, examine the wrist and hands to see the scores. We all know about the scores, Brington score. If the score is 4 or more out of 9, then definitely the patient having hyperlaxity. And in that hyperlaxity scenario, the soft tissue reconstruction or soft tissue repair procedure is going to be fail if not done properly. Number of suture anchor is very important, because previously we have already said that the previously 2 anchors are used, but nowadays it is recommended that at least 3 or 4 anchors should be used in the anterior part of the glenoid. And the mobilization of the soft tissue, there are so many technical things. The preparation of the anterior part of the glenoid, the mobilization of the soft tissue is very important. Putting the first anchor at the 5 or 5:30 position is also very important. So these technical tips and technical things should be kept in mind before doing any arthroscopic Bankart procedure. So at least 4 anchors should be used. If the lesion starts from 6 o'clock, generally it occurs from the 6 o'clock to the 3 o'clock position. Now, these are the other causes of increased recurrence at that time by arthroscopic Bankart repair. It was done in the big chair position, but nowadays almost all arthroscopic surgeons are doing in a lateral decubitus position. That average 2 anchors, the inadequate mobilization of the anterior part of anterior soft tissue, and not adding other stabilization procedure like remplissage, posterior plication. And if the shoulder is unstable, then the rotator interval closure or inferior capsular shift sometimes should be done. And the healing, because if you not adequately prepare the bed, then the bone to soft tissue healing is not up to the mark, as we have seen in the arthroscopic ACL reconstruction with Semitic graft. So inadequate healing is one of the important cause of this failure. Now, shoulder hyperlaxity should be diagnosed, and it has to be differentiated from the shoulder instability. The previous teaching is that the shoulder instability is basically 2 types. One is traumatic and another one is atraumatic. and traumatic generally associated with the unidirectional, and the Bankert repair is indicated in that cases. And atraumatic causes are, that is basically multidirectional instability, sometimes the bilateral, and the main sort of treatment is rehab, the muscular strengthening, and physio, good physio. And if it is not treated by that way, then inferior capsular shift or rotator interval closure has to be done. These are the factors. There's a number of factors. These should be kept in mind. So the history taking of the patient is very, very important. Not seeing the MRI only, the history from starting from the age. Age is very important, because if the patient having less than 20 years of age or more than 20 years of age, there is prognostically, these are the different things. The athlete people, if the athlete is, if the person is athletic, then contact or non-contact sports, throwing or overhead activities, if he has associated with that. Now, history of dislocation and energy associated, this is very important, because if the dislocation occurs several times, that is a 7, 8 times or more, then the dislocation occurs at the mid-range, not only the classical position. There's a 90-degree abduction and external rotation. It may occur at the mid-range, at the 30-degree of abduction or 60-degree of abduction. This dislocation may occur at the night, and this dislocation may occur to do when doing and day-to-day activities. So these histories are very important, because the energy involved to cause the dislocation, if it is, this energy is very less, then there is some serious pathology is involved, and we should look into that pathology. Hypermobile joint and voluntary dislocator has to be noticed. In 2006, the famous Pascal Boileau has introduced this code. This is a busy slide. The instability severity index score. There are several parameters. The total points are 10, but this is a very simple scoring system. The age, the degree of sports participation, type of the sports, the hyperlaxity, the shoulder hyperlaxity come into the account, whether there is an inferior laxity present or not. We have to do the sulcus test, and we have to do the grading, whether the inferior laxity is present or not. The Hill-Sachs lesion, whether is present in a true AP view, or it is present in an external rotation film. If it is present in the external rotation film, then it is significant. And the glenoid loss in AP radiograph, in X-ray. So this scoring is basically, this is basically primitive score, and is basically concerned about the history and radiology, simple X-ray. And there is documentation that if the score is less than 6, then the result of arthroscopic Bankert repair is good. And if it is less than 3, only 3, then the recurrence rate is less than 5% only. But if it is more than 6, then there is 70% recurrence with arthroscopic Bankert repair. Then some open stabilization procedure. In that time, in 2006, most of the bony procedures are open procedure. Arthro-latarjet or arthroscopic ICBG was not popular in that time. So open procedure was mainly done. That is we have seen the open procedure of the humeral head, the Eden Hibernati technique. It was used to fill up the defect of the humeral head. And Latarjet, previous Bristow, was very popular. So clinical examination is very important. The bilateral examination of the shoulder. Any rotator cuff atrophy, that is the atrophy of the supraspinatus, infraspinatus fossa, atrophy of the subscap, because the subscap is a very important stabilizer of the shoulder. And if the subscap is atrophic, suppose the shoulder is very much unstable and patient can't use the shoulder, then there will be disuse atrophy, and subscap atrophy will result in this kind of more this kind of instability. And generally we are making the portals, or we are doing the lateral jet after splitting the subscap. So this makes subscap more weak. So subscap examination of the supra, examination of the infra is very important in this clinical scenario. The distal neurovascular status is important. The axillary nerve, suprascapular nerve, these are the important. The range of motion, apprehension test, definitely the mid-range of motion, and the other test, we all know that there's a crank test, fulcrum test, Jobs test, or the relocation test should be done before any investigation. These are the simple things, X-ray, but these are not simple. The X-ray should be done at the proper plane, because the shoulder is not at the coronal plane. The shoulder girdle is tilted 30 degree in the coronal plane. So the cassette and the beam, the X-ray beam, should be perpendicular to that point, and the torso should be tilted 30 degree towards the cassette. The axillary lateral view, transcapular Y view are also very important. So we can see that this is a normal X-ray in the left hand side, and in the middle X-ray we can see there is an inferior part of the glenoid, some bony chunk is there. So this is definitely bony Bankert lesion, and if it is untreated, then the two things may happen. Then bony Bankert may unite, or bony Bankert may dissolve and creating a bony defect. So bony lesion may be due to the fracture, and bony lesion may be due to the abrasive and erosive effect of the humeral head. So this is the basic pathophysiology of the Hill-Sachs lesion, and the bony deficiency of the anterior part of the glenoid. This is a scapular view. There's a axillary view. We can see that in the left hand side, we can see there's a big Hill-Sachs lesion, and there's a true AP view of the shoulder. We can see the Hill-Sachs lesion and the bone loss, the superior humeral bone loss, and also the glenoid profile. But for glenoid profile, there is a very good view for this academic purpose. I am showing this is a Barnagew view. So Barnagew view is basically taken with the arm abducted 70 degree. So 70 degree, more than 70 degree abduction of the arm, and the X-ray beam should be directed craniocaudally at a 30 degree, and as the shoulder girdle is tilted 30 degree, so the torso should be tilted to the 30 degree, and the beam should be 90 degree to the cassette. So this is, on the right hand side, we can see the glenoid profile. In the normal side, the anterior part of the glenoid is very sharp, but if there is bone loss from the anterior part of the glenoid, this sharpness of this part is lost and it becomes blunt. So this blunting, there is a sign, is called cliff sign. So cliff sign is basically loss of sharpness of the anterior inferior part of the glenoid, and it is commonly associated with recurrent dislocation of the shoulder. MRI is a very much common investigation. If the patient tells about the recurrent dislocation of the shoulder, the first thing we write is an MRI of the shoulder. So MRI tells many things. Apart from the anterior part of the glenoid, the lesions, there are several other things. We can see the glenoid. We can see the end-face view of the glenoid. So what is the end-face view? The end-face view is basically a glenoid view when the humeral head is not there, and this view is continuous with the coracoid. So we can see the coracoid, and we can see the face of the glenoid. And if in that view there is some bone lesions in the anterior inferior part, there is definitely a bony Bankert lesion. And other things are, we can see the subscap. We can see this is a subscap. We can see the supra and infra. And associated lesions like slap lesions is associated with this anterior is with the Bankart lesion, we can pick that also. So glenoid erosion is present around 5 to 56% of cases of chronic anterior shoulder instability. So just think that the half of the cases of anterior instability may have this glenoid erosion. So if the glenoid erosion is there, the best investigation is do a CT scan, because MRI can't quantify a bony lesion and can't quantify about the percentage of the bony lesion. So what is the implication of this bony lesion? This loss of anterior glenoid concavity reduces the effectiveness of concavity compression mechanism, and less force is required to dislocate the shoulder. So the less force, the support in the anterior part is lost and the shoulder dislocates very easily. Glenoid track is a emerging concept. It is described by Yamamoto in 2007. So what is that? This glenoid track is very important to diagnose, to manage a recurrent shoulder instability. So we have to know it. So what is glenoid track? It is basically the contact between the glenoid and the humeral head with the maximum external rotation and maximum extension of the shoulder from 0 to 90 degree of abduction. So the path of the humeral head in the glenoid from 0 to 90 degree of abduction with the full external rotation and full extension. Generally, the heel sex lesion, if extends medially, it falls into the glenoid tract and there is a risk of engagement and dislocation. So in that picture, we can see that as there is a gradual abduction of the shoulder, so the contact area goes from anterior inferior part of the humeral head to the posterior superior part of the head, and if the heel sex lesion is there, then there is engagement and dislocation. Normally, this humeral head traverses the 84% of the glenoid width, and it is called the glenoid tract. So it is the contact with the full abduction and external rotation. Now the gold standard test is CT with 3D reconstruction for the glenoid and also for humeral head. And we have and we have seen the best fit circle method is a method for quantifying the glenoid bone loss, and it is described by the Sugaya in 2003. So the amount of glenoid bone loss can be quantified as a percentage of either total surface area or diameter. So this is a diameter method. Diameter method is the best fit circle. This is a glenoid end face view with a humeral head subtraction. We can see both the sides, but in the CT scan. But in MRI, we can't compare with the normal side. But in CT, so the CT is very important. We can compare with the normal side and quantify the amount of defect. So diameter method is popular. It's a very popular method. So percentage of bone loss is a defect. How much is the defect of a fully matched circle at the inferior part of the glenoid to the total diameter of the inferior glenoid circle into 100%. So there is a critical limit for it. A different author has described the different limit. The Itoi have described it is 6.8%. Packard and De Beer has popularized the inverted pear shape, and it is 7.5 millimeter. And Low et al. It is seen as 8.6%. So basically, we see in Indian scenario, Indian population is generally cutoff mark is 6 millimeter. 6 millimeter of glenoid bone loss, and it generally comes around 25%. So this comes the bipolar bone lesion. Sorry. So what is a bipolar bone lesion? if the bone lesion is present simultaneously in the humeral side and in the glenoid side. We can see this bipolar lesion and we can say whether it's on track or off track by measuring this glenoid tract. So if there is bone loss from the anterior inferior part of the glenoid, this 83% tracking is reduced by amount of bone loss. So it is generally 0.83 by this total diameter minus the amount of bone loss. It is compared with the Hill-Sachs index. So what is that? The amount of Hill-Sachs lesion with plus bony bridge. I am coming to that later on. So that is this. So if the Hill-Sachs lesion is more than the glenoid tract, so in that case the glenoid tract is less than the defect. So generally it is off track and it is engaging, and if it is less, then it is a on track lesion. So this classification is very important for future management. This is a model, and we can, the 3D model, we can see that if there is no bone loss in the front of the glenoid, the Hill-Sachs lesion still is contoured within this glenoid. So there is no engagement and no dislocation. But if the tract, if the road, if the path is reduced by the bone loss in the anterior part of the glenoid, then there is engaging of the Hill-Sachs lesion with the anterior part of the glenoid, and there is a dislocation. This is the arthroscopic view. We can measure the Hill-Sachs lesion, and we also can measure the bone lesion in the anterior part of the glenoid. So this is the big Hill-Sachs lesion, and this is the off-track lesion because this joint is dislocating as we can do the abduction and external rotation intra-op. So apart from preoperative investigation, we also can see it intra-op by seeing the bony defect. So we have to compare in both the sides. After arthroscopy, after doing anything, we have to see whether it is on track. We can actually measure the amount of bone loss by the calibrated probe. We have the calibrated probe. This is generally 4 mm, 3.4 to 4 mm. With this calibrated probe, we can measure the bone loss and we can plan accordingly. So this is a general planning. If the glenoid defect is less than 25% or more than 25%, this the cutoff mark is 25%. And along with that, if the Hill-Sachs is on track or not off track. So between these two, comparing with these two in permutation combination, the management differs. So if the glenoid defect is small and the Hill-Sachs lesion is also small, then we can easily go away with the arthroscopic Bankart repair. But if the Hill-Sachs lesion is large and it is the off-track lesion, then some amount of soft tissue procedure apart from the Bankart repair has to be done. That is the remplissage. Remplissage is basically the tenodesis of the infraspinatus with the Hill-Sachs defect. We can do in arthroscopically most of the time, but we also can do in open method by 1 or 2 anchors. If it is large, then 2 anchors can be used, but if it is small, then 1 anchor is sufficient. And if the lesion is more than 25%, the glenoid lesion is more than 25%, it is on track, then Latarjet procedure should be done. And if it is off track, then along with the Latarjet, then remplissage or humeral bone grafting, or sometimes the hemicap is given to fill the bony defect. So there's a controversy. Then when we will do the Latarjet, when we will do the remplissage, when we will do the Bankart. So these things are basically depend on your preoperative investigation and your intraoperative findings. These two things you have to corroborate to make a final solution. This is a classical Bankart lesion in the anterior inferior part of the glenoid. We all know that it is managed with the 3 to 4 anchors, is used, and the steps we have already told. So these are the anchors we are giving. So 3 and 4 anchors are better, and after the placement there should be a bony there should be a soft tissue bump in front. So this bump is very important to mobilize after mobilization of the soft tissue from the front. This is a normal glenoid, and after bone loss it becomes pear shaped glenoid, and we can see both in pre-op and intra-op. So basically, if there is a bone loss, if more than 25% bone loss, then latter J is the answer. So why latter J? Because it is not only fills the defect, but also it gives a hammock-like support at the anterior-inferior part of the glenoid in the abduction and external rotation. It supports the inferior part of the glenoid. When there is a abduction and external rotation due to the contraction of the biceps and short head of the biceps and coracoracalis, the inferior subluxation is reduced. So generally, the dislocation may be voluntary or habitual. In that case, don't jump into the surgery. Basically, the strengthening of the muscle, the rehab exercises, physio is sufficient, and we have to see this when we have to differentiate it from shoulder dyskinesia. We also the scapular dyskinesia nowadays we are finding in our clinic. The multidirectional instability, the surgery if required, when the non-operative treatment fails, then lateral capsular shift or the medial capsular shift can be done. This is a capsular application. The steps of the surgery, the redundancy of the anterior-inferior part of the capsule and labrum and IGHL is closed. So, in summary, the traumatic first-time dislocation, there's a most of the cases we treat this conservatively, but there is controversy, the recent controversy about the arthroscopic Bankart repair in the first-time dislocator. But we are not coming into detail. The traumatic recurrent dislocation, always the surgery is the answer. Posterior dislocation, commonly seen in epileptic patients or any other patients with bony deficiency or congenital deformity. So the conservative treatment most of the cases is relevant. Sometimes if there is a posterior Bankart lesions, then has to be treated accordingly. Multidirectional instability should be treated with conservative method, and habitual dislocation. So conservative for all the patients of habitual dislocation is the answer. So only the anterior glenoid rim deficiency, the Bristow, or after that the latter J procedure, if it is 25 or more than 25. But if there's a major glenoid bone loss, there is a more than 40% of the glenoid bone loss, then latter J is not the answer. Or sometimes there is a revision cases after latter J. Then the iliac crest bone grafting. The iliac crest bone grafting is a treatment of choice. It is done in the open method, or it's also done in the arthroscopic method. Impingement, if occurs secondary to the instability, always treat the instability first. An elderly patient with dislocation, always think of rotator cuff injury, and repair of the rotator cuff generally make the shoulder stable. This is another patient of 32 years, recreational cricketer, history of dislocating right shoulder 4 times. And after dislocation, he given up the sports, and there is a jobs test, apprehension test is positive, and crank test is negative. The X-ray, we can hardly see any or minimum Hill-Sachs lesion. There is no change in the glenoid. We can see from the X-ray. And in the MRI, the first investigation, we see there is a big Bankart lesion, and there is a Hill-Sachs lesion also. So in that case, the thing is that the less than 25% of the bone, there is no bony deficiency of the anterior part of the glenoid, and there is an on-track lesion with uh, on-track bipolar lesion. That is there is no bone lesion in the anterior part of the glenoid, only Bankart or and the Hill-Sachs lesion. So we can manage it with the help of this remplissage technique. First we take the bite. Uh, after entering, we take the bite, or put the anchor, take the bite of the infraspinatus, but we don't suture it. We don't suture it. After doing the Bankart procedure, after putting 3 or 4 sutures, the 3 or 4 anchors in the front, we last tie this remplissage knots. And after 3 months of follow-up, this is a patient, and he is now planning to play the cricket. Okay. Now this is the first case. This is the first case. We have seen the 7 to 8 times dislocation with the kabaddi players. The CT scan shows there is a bony lesion from the front. This is a bony lesion, and we can measure the bony lesion in the CT scan, and we are planning to do the letter J. Generally, the letter J can be done in the arthroscopic manner nowadays, but these results are very good in hands of the expert surgeon. But the common surgeons, there is no harm in doing the letter J in the open fashion, because if there is putting the graft in a not proper way, that is, if it is overhang, lateral overhang, then there is a high chance of glenoid osteoarthrosis, and if it is too medial, then it will not serve the purpose. The shoulder remains unstable. So the putting the graft in the front of the glenoid is very important. Second important is a screw trajectory. Screw trajectory should be, there is an angle, it should be within 20 degree from the face of the glenoid, because if it is more than 20 degree, then there is a chance of suprascapular nerve injury. And the length of the graft is also very important. It should be more than 2.5 centimeter. These are some intraoperative photographs of this letter J. We have exposed the coracoid after a deltopectoral approach. We have exposed the coracoid. The coracoid is harvested after clearing the medially and laterally. Medially, there is a pec minor. We have to erase at the bone after the grazing the bone, because underneath there is a brachial plexus, so we have to take care of that. And anteriorly, we are keeping some part of the CA ligament for future repair. So we are harvesting, and we harvest the coracoid at the junction of the horizontal and vertical part, because if it is too much in the horizontal part, then the graft length will be short, and it is too medial in the vertical part, there is a chance of damage to the coracoclavicular ligament. So this angulation is important, and we can use an angulated saw, or we can use osteotome for that. And we have harvested that. Then we have marked the subscapularis. We have marked the superior 2/3, inferior 1/3 junction. We have split it, the subscapularis. We cut the capsule. We reach up to the glenoid, anterior part of the glenoid. It should be retracted with this beautiful. There's an anterior glenoid retractor is there. We have to retract it. And the preparation of the glenoid, the anterior glenoid bed is very important, and the preparation of the coracoid process is very important, because if the preparation is not there, then there will be no bone to bone healing. And after the preparation, we fix it with the help of 2 cannulated cancellous screw, and also is an important thing to check the glenoid from the front with the help of a Fukuda retractor. The Fukuda retractor should be inserted at the glenohumeral joint, and we have to see from front whether it is actually matching the front of the glenoid or not, because it is very important. It is overhang, there is arthritic. If it is medial, then there will be gradual absorption of this bony fragment, and it will not serve the purpose. And remember that the latter J procedure is basically the shoulder anatomy is distorted. The revision is basically a nightmare. So the first procedure, the index procedure, should be as perfect as possible. This is a post of X-ray, and this is a clinical photograph of the patient after 2 months, and the shoulder is stable. But there are some pitfalls of the latter J2. It is not the answer for all the cases because it causes permanent distortion of the shoulder. So the revision is very difficult. The violation of the subscap is there. Though we repair it, the violation causes the dysfunction already if it is already atrophic or some amount of thinning is there. So it causes dysfunction. Non-anatomic placement has several outcomes, several poor outcomes. Neurovascular complications are more with the latter J, and it is a very steep learning curve. So the axillary nerve and the brachial plexus should be very very cautiously should be dissected at the time of latter J, and the artholateral the coracoid harvest is also difficult. So there is a no harm in make it open in the small deltopectoral approach. Make it open, put the graft perfectly over the anterior part of the glenoid. The ICBG is coming up with the bone loss when it is more than set 40%. When the latter J is insufficient, or the revision cases, though there is a chance of more chance of arthritis because the coracoid matches flush with the anterior part of the glenoid, but very difficult for the tricortical graft to match the anterior part of the glenoid. So there is some sort of problem is there, but it helps in a robust support in the anterior part of the glenoid. And this is a paper in 2016, the arthroscopic iliac crest bone grafting to the anterior part of the glenoid. It shows the arthroscopic anterior glenoid augmentation using iliac crest bone graft that does not violate the subscapularis. This is very important from the latter J. By creating the far anteromedial portal, we generally use the mid pectoral portal in ICBG. So it doesn't violate the subscap. It is just the superior part of the subscap, and it travels the superior to the subscap, and the arthroscopic Bankart capsular repair is often performed after that. After the ICBG, after placement of the graft, we generally make this graft extra-articular by doing a Bankart repair at the end. So this is the picture, some picture of this arthroscopic ICBG. This is a preparation of the anterior glenoid bed, and this part is the dissection of the conjoint tendon. It's a very very critical and very very careful, because the musculocutaneous nerve is 5 centimeters from the tip of the coracoid, and it's a medial border of the conjoint tendon. So very precious about this location. And when dissecting with the RF, and the medial, in the medial part there is a brachial plexus, and after harvesting the graft, after matching the anterior part of the glenoid, we generally fix it with 2 cc, and finally we close and make the graft extra articular with placement of the 2 or 3 anchors in the front, and repair the Bankart lesion. So thank you all for this listening presentation. Hello.
Yes, sir. Thank you for your nice presentation. Sir, can we wait for 2 minutes if any attendees have any doubts, so they can ask us?
So any question?
Sir, I am requesting to all the attendees, if you have any query, please raise your query in the chat box. Sir will be happy to answer you.
Yeah. Any question? I am very glad to question, answer any question. So please, if any question is there, any from technical part, from management, from diagnosis, any part.
Yes, sir. We have one question from Dr.
Yeah,
Shyam, sir.
Dr. Shyam Sharma. So, doctor, how is your, sorry, this question is not visible. How is your experience with external? Yes, external rotation restriction is definitely it is there with the in remplissage, because we are using the infraspinatus. We are doing the tenodesis. For this tenodesis effect, this of this infraspinatus, the external rotation, the terminal 10 to 15-degree terminal restriction of the external rotation is there in with the remplissage, and also some lethargy also. There may be some external rotation deficiency, but it is more common with remplissage. I'm telling you, it is more than lethargy, because theoretically it has to be. Any other query? How to proceed in Bankart, and what is the average recovery period in young athletes? Yes. So in young athletes, we generally, if this is only Bankart lesion or unipolar lesion, we generally go ahead with this arthroscopic Bankart repair, and after say healing of uh, 3 months onwards, generally contact sports, we don't allow any contact sports 6 months from the surgery, and generally the day-to-day activities can be done after 6 weeks. Range of motion is started as early as possible, but abduction and external rotation is delayed for more than 6 weeks. So this is our protocol in arthroscopic Bankart repair. Okay, thank you. Any other query?
So, sir, there are no more further questions.
Yeah,
So, with your permission, can we conclude from here?
sure. You just make the conclusion note and finish it.
Okay, sir. Sir, on behalf of Lupin, I would like to thank you for your insightful and educative talk, sir. Thank you very much for your valuable time, and thank you all the attendees for patient listening. Thank you very much.
Okay, thank you. Thank you.
Okay, sir. So, sir, from here I'm ending the session. Thank you.